Hi guys, welcome back to the channel. I hope I find you all well. Thank you for watching the previous videos that I put up. My name is Lisa, if you don't already know, and I am back to do chapter 2 of Beyond Death's Door, and also the next chapter of Return of the Gods, blah blah blah. Those videos will be out later. So yes, I have been up so early this morning. I have spoken with the Lord, read my Bible. I just find it so interesting. And then hopefully this afternoon I am hoping to plant my onions, which I'm hoping to film. Now guys, I'm going to admit I'm not great at this filming stuff. I'm not good at this editing stuff. I don't even know how to edit. So that's why the videos are kind of... Oh, I've just got something pop on my screen. Sorry guys. So that's why my videos are unedited. What you see is what I filmed and I just put it straight out there. So yeah, I'm sure as time goes on I'll get better at these things. But yeah, this is not my comfort zone at all. I'm just doing what I've been called to do. So let's take a look. So we've been reading Beyond Death's Door. Chapter 2 is called Bring 'Em Back Alive. So let's crack on, guys. We in the medical trade spend much of our time dealing with death, preventing it if we can, and retrieving people from it whenever possible. We have a word for this method of bringing them back alive: resuscitation. Before we get into actual life after death reports, I'm going to devote this chapter and the next to a discussion of two basic areas that will help you better understand the after death experiences themselves. This chapter will be given over to resuscitation, how it works and how its relationship to the experiences of the dying patient. Then in chapter 3, I want to focus in on why we die and some specific things we can all do to keep our bodies healthy. I've taught resuscitation methods to others for about 15 years. The methods outlined in this chapter will help you to respond effectively to the sudden death of a companion. Whereas old methods were rarely successful, continued new refinements in resuscitation can now bring restoration of life to greater than 50% of all sudden deaths not involving catastrophic injury. Without any equipment and using one's bare hands, anyone with minimal training can use these techniques with some success. Resuscitation is the art of induced breathing with your breath and simulated heartbeat with your hands. Resuscitation is the most ingenious and simple way to bring the clinically dead back to life. Death as experienced prior to resuscitation is difficult to define and understand. Strange encounters may occur during such experiences. Reversible death or clinical death is that type of death that is potentially recoverable by restarting the heart and lungs. The brain and underlying vital tissues have not yet died. When the brain and vital tissues die, irreversible death or tissue death has occurred. Resuscitation from reversible death should certainly not be confused with resuscitation from irreversible death. One requires training, the other a miracle. Almost everyone will see an unexpected sudden death during this time and therefore should know how to restore the victim to life. There's no time to wait for help from others. Basic resuscitation techniques. Resuscitation consists of artificially induced respiration and circulation. Respiration is accomplished by mouth-to-mouth breathing, which is administered manually by closing off a patient's nostrils while forcing air into their lungs through his mouth. When properly done, the unconscious victim's chest will expand with air. Exhalation of this air automatically occurs from elastic recoil of the dead person's chest when you momentarily remove your mouth to allow for the next breath. Circulation is maintained by externally massaging the heart. This is done by placing the heel of one hand on the lower portion of the breastbone and the other hand on top of that and pressing down to squeeze the heart between the yielding and breastbone in front of the rigid backbone behind. Simulating a heartbeat. The cycle is interrupted after every 15 compressions for 2 quick breaths into the victim. If you're working alone, massage time is equally divided between compression and relaxation, and 60 to 80 beats per minute are delivered. Since heart bells are designed to flow one way, the heart blood is compressed forward into the arterial blood vessels, and the heart passively refills itself between compressions. If properly done, the pulse can be felt as an expansion in the neck vessel, just beside the Adam's apple, or the carotid artery. This pulsation will confirm a correct procedure regardless of the patient's subsequent survival. No longer is it necessary to surgically open the chest and expose the heart for a direct massage. The present method is just as effective for recovery. Speed and efficiency in administering resuscitation is key to recovery in these cases of unexpected death. 98% will survive if pulse and breathing are assisted within 1 minute after death. If within 2 minutes, 92%, within 3 minutes, 72%, but only 50% will survive if 4 minutes elapse and only 11% after 6 minutes. Airway obstructions. Obstructed airways caused by choking or asphyxiation can contribute to 50% of all deaths. Obstruction should be suspected when the patient struggles to get air into his lungs without much success. Sometimes a crowing noise can be heard as the patient inhales air past a partial obstruction. Struggling without a noise is a grave emergency, indicating a complete obstruction. Death will occur quickly if not relieved. Subsequent resuscitation may dislodge the obstructing material, but any resistance encountered when forcing one's breath into the victim's lungs is evidence of continued airway obstruction. Failure of the chest to visibly expand with air further confirms an obstruction. The most common airway obstruction in the unconscious patient is due to relaxed tongue sagging against the back wall of the throat. The patient does not swallow his tongue, although the concept is comparable. Elevating the chin upward and extending the top of the head backward towards the floor when the patient is lying on his back will usually permit immediate, smooth and obstructed breathing. Many unconscious patients die due to simple suffocation from obstructing tongue, which could be easily corrected. The American Heart Association is attempting to instruct everyone, including all elementary school, in how to recognize and treat an obstructed airway. For example, if a child escapes injury in a devastating automobile accident with his family, he should know how to elevate the chin of an unconscious family member until the ambulance arrives, preventing death from suffocation. Other airway obstructions may be due to improperly swallowed meat, inhaled food particles, false teeth, or anything that may result in a blockage or closure of vocal cords. Any obstructions that the patient can't remove through coughing can often be expelled by abdominal or chest thrust maneuvers. These are performed by forcibly squeezing in on the lower chest or upper abdomen. Such techniques force air out of the lungs in an attempt to dislodge the material from critical area of the windpipe into an area of the throat where it can be removed. Excuse me, guys. Mouth-to-mouth resuscitation may also dislodge the obstruction by blowing the foreign material from the windpipe down into one of the lungs. The victim is often able to maintain breathing with the remaining lung. The foreign body can be subsequently be removed from the lung at a more convenient time through an instrument called a bronchoscope. The bronchoscope is a hollow tube that is passed through the windpipe into the lung, through which the obstructing material can be grasped with forceps and removed. I recall an unfortunate story concerning one of these beautiful daughters of Colonel Antonio A. Batres, Chief of Guatemala's Air Force. I was flying to Guatemala to deliver some relief supplies and thyroid vaccine that had been donated by fellow physicians in Chattanooga for earthquake victims there. Just a week before the earthquake, Colonel Batres's daughter, who was in her 20s, had gone to see a dentist in downtown Guatemala City. During some dental procedure, it was not clear whether it was filling or an extraction. She suddenly developed a wheezing noise. She couldn't breathe. She turned blue and became unconscious. Having never encountered a case of airway obstruction during his many years of practice, the dentist didn't know what to do. He ran into the streets of downtown Guatemala City yelling, "Help, help." In the meantime, she died. Had he known and followed the basic steps just outlined, her death could have been prevented. So, quick note. I don't know if you've ever seen resuscitation or anything like that, but you like interlock your hands over the other and you compress the chest with this, and it would be like just where it meet it there. So you put your hand there and that's where you do your compressions. And we was taught in training, because I used to work in care for elderly and mentally ill people. They used to do it to the beat. So do, 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 and you just go to that beat. It's kind of like in here, in England, they used to have an advert that played the song "Staying Alive," and then you do it to like the beat of that song. So now, whenever I think of chest compressions, I think of that song. Sad, I know. And I'm sure that's not what will come to my mind if I ever have to do that. And obviously, tilting the head back. If you was, let me just turn around like this, and someone was lying on the back, you just tilt their head so their chin's up, just like that. So I'm not a medical doctor, guys. I've just had first aid training because obviously working in the care environment and looking after people in the so I was trained as a first aider. So yeah, in the event that you want to know that, you never know, guys. Everything happens for a reason, and you never know, there might be someone watching this video or one of us that are going to be called to actually have to use these skills. If you're worried about doing mouth to mouth on somebody and physically, like a stranger, you can actually buy mouth guards. It's like a little tube and it's plastic around, so it's just you breathe onto the mouth guard instead of directly onto the person's mouth. You can just carry one of those around in your bag. But yes, anyway, God forbid that we have to do things like that, because one, it's extremely exhausting and I can imagine it to be quite distressing. So yes, so it's interesting we're covering this, but you never know who might see this video and actually be glad they received the information. And I'm sure on YouTube there's a million videos of how to do resuscitation, so you can always go find one there. Right, survival time. In more than 100 ambulance calls made in response to victims with sudden death, cardiac arrest in Seattle, it's been found that 18% can only be brought back to life if public waits for resuscitation by ambulance crews, who, in this study, took only a few minutes to arrive. On the other hand, the long-term survival rate was more than doubled, with 46% recovering. If the passerby instituted immediate resuscitation before the ambulance arrived, this diminished that critical time the patient existed without a heartbeat or breath exchange. It is here we need public education. The brain has only 4 minutes survival time without heartbeat and blood supply. Even a physician living next door would not do much good for an average victim of heart arrest, be it from heart attack, drowning, electrocution, poisoning or suffocation. It would be much longer than 4 minutes survival time before the doctor could possibly initiate resuscitation. It's important that everyone therefore become familiar with the cardiopulmonary resuscitation, CPR. This training is available in detail through your local branch of St. John's Ambulance Brigade or Red Cross in almost all cities. I urge you to take it. US ambulance crews are being authorised to start advanced life support measures at the scene of an emergency, rather than waiting to administer such treatment after the patient arrives at the hospital. Advanced life support measures now include electrocardiograms to detect and treat abnormal heart rhythms, electrical defibrillation, shock when necessary, intravenous lifelines for the administration of drugs, insertion of airway devices for controlled breathing, and special methods of transportation. Many of us can recall observing a case of sudden death. It's not common. I recall the unexpected death of... it's not uncommon, sorry. I recall the unexpected death of a good friend a few years ago at Callaway Gardens, a plush resort in Georgia. While bicycling at this resort, my friend, who was in his 40s, started complaining of gas in the centre of his chest. It was a first for him. Sorry, guys. We had flown there to play golf, swapping his lessons in golf for mine in flying. My golf that day was awful as usual, so the opportunity to bicycle with our wives was a welcome change. However, his indigestion became increasingly painful and spread into his jaw and arms. He decided to lie down on the lawn. The pain got worse, and as he became pale and breathless, everyone started gathering around him. Suddenly, he arched his back in a stiff convulsion, sputtered, rolled his eyes upward, stopped breathing, and turned greyish blue. I started mouth-to-mouth resuscitation with 4 quick breaths, tilting his head back toward a good airway and closing his nostrils with my fingers. Feeling no pulse and hearing no heartbeat with my ear to his chest, I started external heart massage. He finally opened his eyes and tried to speak, but each time I interrupted resuscitation, he slipped back into a deep coma. Then he would partially awaken again, half grimacing, half smiling, and reach for a point at something. I believe he was trying to tell me something, but I didn't take the time to listen. I was more concerned with finding any available medications. During all this time, he had no heartbeat of his own, but was sure he was in ventricular fibrillation, which is silent twitching. With no monitoring instruments or equipment, I knew I had to continue to maintain resuscitation during the long ambulance trip back to the hospital, where the defibrillator could be obtained. The ambulance arrived and we lifted him in. It so happened the ambulance did carry a portable defibrillator unit, but it hadn't been checked recently and was found to carry no charge. We stopped at a farmhouse along the way to plug it into their electricity for recharging the defibrillator, but it wouldn't charge. The instrument was useless. When we arrived at LaGrange Hospital, almost 2 hours had elapsed by the time electric shock treatment proved futile. Of course, I wonder now what really transpired. What was he trying to say? I missed the opportunity to listen to him during those important moments. I did not ask him what he saw, where he was, or what went on. I have allowed many such opportune moments to escape in the past, but no more. One of 500,000 Americans who are at risk of dying of heart attack each year, called myocardial infarction. More than 300 160,000 die before they can reach a hospital. Since most die in the first 2 hours, 60% of patients with acute myocardial infarction never reach a coronary care unit. Most of these early or sudden deaths appear to represent ventricular fibrillation, which is a twitching or non-contracting heart. If we are effectively reduce mortality, we must inform the public not only of the heavy squeezing mid-chest pains of the heart attack, but also of the necessity of early and prompt hospitalisation. Present statistics suggest that elapsed time between onset of complaints and admission into a coronary care unit is appallingly high, estimated at 9 hours as a national average. Furthermore, if sudden death occurs in the home or office, the average available person has had no training in resuscitation or is too afraid to use it by the time qualified help is contacted. The 4-minute time limit for brain survival has expired. Perhaps we need to focus more attention on this pre-hospital phase and concentrate on greater education and training of the public. So, life after death. Only recently have there been a sufficient number of survivors of reversible or clinical death to be worthy of comparative analysis. These recent revelations have stimulated current interest in the subject of life after death. Unfortunately, only about 20% of resuscitated individuals describe an experience outside of the body after death. Others may decline to admit such experiences, especially if their experience included being sent to hell. Many people may be reticent to discuss their personal experience for fear of being labelled eccentric or strange, or for fear of being ostracised by their friends. Once the subject of life after death is freely discussed, however, the fears of rejection are often replaced by a sympathetic rapport found by confiding in others with similar experiences. If conditions for discussion are made more favourable, further accumulation of after-death reports can be anticipated. The ability to restore life has opened the door into this corridor we call death, allowing us to peer through the eyes of others to what may lie ahead. In summary, let's outline the steps for emergency resuscitation to use until help arrives. 1. Confirm unconscious first. So that's normally by putting your ear to the mouth and looking down at the chest. If you don't see the chest rising and falling, that's when you need to start compressions. So open the airway by tilting the head back and check for breathing. If breathing stopped, give 4 quick breaths. Check neck pulse. If no pulse, begin external heart compression by depressing lower half of the breastbone 1.5 to 2 inches rhythmically. Continue uninterrupted cardiopulmonary resuscitation, giving 2 breaths after every 15 compressions until advanced life support is available. Again, let me say that for you to develop confidence in your ability to use CPR techniques, you should take the course, usually consisting of 1 or 2 meetings, offered by St. John's Ambulance Brigade or the Red Cross. The appendix in this book also offers a detailed description of the modern resuscitation techniques. Where are we? 18 minutes. Okay, I will keep it short and sweet on this video, guys. And then the next one's how you will die. And obviously he's going into detail on these kind of things in these 2 chapters. I've not read this book, so we'll see as it goes on. And then after that, it's the concepts of death, strange encounters, ascending to heaven, death, and heaven. Yeah, ascending to heaven. And then descending to hell. So yeah, there's quite a few more chapters yet, guys. And then when you're dealing with the dying and stuff. So yeah, it's quite an eye-opening book. So yeah, that will be interesting to go through and finish. Like I said, thank you guys for watching my videos. I really do appreciate it. And thank you, bless you, to those that have liked my videos. I know not all of the likes come up, or when I've got new subscribers, my numbers and stuff don't always match up. But hey, it doesn't matter. Don't worry about it. But thank you for letting me know that these things are happening, but this is just the wonderful land of YouTube. So thank you guys for watching. I will be back with your next video soon, and yeah, I will continue to pray for you all and the Lord's guidance with this channel. And yeah, thanks for watching. I'll see you all in the next video.